Hello, future nurses. Today we're going to be talking about our oncology lecture. This goes through chapters 19 through 21. So before we begin, I just wanted to kind of talk to you about some of our learning objectives. These are just general learning objectives that should be achieved by the end of the lecture. With it, it's different things like applying basic biological understanding of cellular overgrowth, malignancy, everything of that nature. So hopefully by the end of this, you'll be able to kind of go through these and see, are you able to understand it, interpret it, distinguish between these different concepts? And here's another group of learning objectives as well. It's just continued. Like, are you able to know what your teaching strategies would be when it comes to appropriate protective measures for our oncology patients? This slide here basically goes through all the different chapters and where they discuss oncology. So for example, chapter 61 talks about bladder cancer. Chapter 41 talks about brain cancer. So any of these chapters here that you've gone over in a previous class, my suggestion would be to just kind of go back and kind of refresh yourself, especially before NCLEX, when it comes to these concepts. Okay, so the first thing we're going to be talking about today are cellular components. So we're going to kind of break it down cellularly and then move on to what we need to know as the nurse. So these are things like our normal, benign, and malignant cells. So the next couple of slides are just general terminology. They're not necessarily NCLEX in themselves, but these terms are often seen in NCLEX questions. So you want to be very familiar with things like if you see hypertrophy, you know that that's an increase in individual cell size. So you want to be able to kind of look at these terms and just know what they're talking about. And I gave some examples too, like, for example, if you're hypertrophy, you can have physiological, which is basically exercise. That means that the cells grow when you exercise, especially like with things like weight training. But pathophysiological, which is increase in cellular size without increase in supportive structures. So that would basically be, for example, high aortic blood pressure equals high workload for the left ventricle, which equals left ventricular hypertrophy. So like I said, these terminologies are mostly just as a refresher. So that way, when you see some of these terms, it doesn't just come as such a shock. And once again, this is just some more terminology. We've got things like our metaplasia, which you probably heard a lot of when we were talking about things like GERD. And basically what happens with that is the cells take on a different form. So since GERD is that gastric contents coming up through your esophagus cells aren't prepared to kind of take care of it the way your stomach cells are. So they are transformed into this metaplasia. And neoplasm is our new growth. So a lot of these you'll see us talking about a lot more when it comes to some of our oncology. I like this picture here because it shows a representation of the different cells that we had just talked about. So we've got hypoplasia, hyperplasia, neoplasia, dysplasia, metaplasia, anaplasia. So it kind of shows all these different disorders. So this is the biology of normal cells. You have specific morphology, which basically means this is the feature in which normal cell types have a distinct and recognizable appearance, size, and shape. So each cell for a normal cell should be very distinct in the way it looks. The next thing you have for biology of normal cells is a smaller nuclear to cytoplasmic ratio. Basically, what this means is that the nucleus of the normal cell accompanies a relatively small amount of space inside the cell. The size of the normal cell nucleus is small compared to the size of the rest of the cell, including the cytoplasm. Differentiation is the function, which means that every normal cell has at least one function it performs to contribute to the whole body function. An example for this would be skin cells make keratin, liver cells make bile, cardiac muscle cells contract, and red blood cells make hemoglobin. Tight adherence occurs because normal cells make sticky cell adhesive molecules that protrude from the membranes, allowing cells to bind closely and tightly together. Non-migratory means that the normal cells do not wander throughout the body. Orderly and well-regulated growth by cellular regulation is a very important feature of the normal cells. Basically, they divide for only two reasons: to develop normal tissue or to replace lost tissue. Contact inhibition, part of cellular regulation that stops further rounds of cell division. Apoptosis is programmed cell death, and epilepsia is having a complete set of normal chromosomes, so 23 pairs of chromosomes. So with this, the reason we talk about all these different things, and it's more about understanding what you're kind of looking at. The reason we talk about this is in reference to what is normal versus abnormal. So all these things here that we kind of talked about, and I don't want you to get too caught up in trying to be overwhelmed with this. It's more about just understanding of what does a normal cell look like opposed to a benign cell, opposed to a malignant cell. What causes these cancer cells to be so dangerous to our patients? This picture here just indicates what a normal cell appear like under a microscope. So it's basically very helpful in showing well-differentiated cells. And you'll hear that term a lot, well-differentiated, because basically what that is it not moving into another cell? Is it very much just its own functionality? And this definitely helps to contrast with cancerous cells that do not hold shape, so they kind of lose that functionality. Because if you look at each of these distinctive morphology of your normal cells, they're all designed to help with something. For example, with our neurons, they're designed to send those electrical impulses. So it's got a very much needed design. So this is just a general overview of benign versus malignant tumor cells. So for your benign cells, and when you see these, it kind of makes sense why when we talk about it, we say that benign, we're not as worried about it as when it comes down to malignant. So with your benign, they're usually normal cells. They're cells that are growing in the wrong place or at the wrong time as a result of a problem with cellular regulation. And some examples can be things like moles, skin tags, endometriosis, polyps, all these kinds of things that while they cause irritation, it's not like they're spreading. They're kind of within that normal, or they're within that normal cellular area. Malignant are abnormal. So these are when we're starting to lose that tight adherence. They serve no useful function and they're harmful to the normal body tissues. So that's why, like, when we talk about this in a very general way, we're more concerned about our malignant cells than we would be about our benign cells or benign tumor cells. So once again, this is the biology of a benign tumor cell. So in contrast, you can see that there are some things that are different between our normal cells and our benign cells, but there are some things that are the same. So with it, we've got specific morphology, smaller nucleic to cytoplasmic ratio, specific differentiated function, tight adherence, no migration, which is a very kind of important concept when we're looking at malignant versus benign, orderly growth, and normal chromosomes. So with those benign, as you can see, there are some things that are different than our normal cells, but it's not like they're doing the spread as we would with our malignant cells. So with our malignant cancer cells, these ones have a much more invasive sort of attribute to them. And we're going to kind of go over some of these different concepts here. So when we're looking at this with a malignant cell, you're going to see things like anaplasia, which we'll talk about, a large nuclear to cytoplasmic ratio. Your specific functions are lost, loose adherence, so they're not all sticking together, increased migration, contact inhibition, so very invasive growth, rapid or continuous cell division, and abnormal chromosomes. So looking at this anaplasia, so I kind of like this picture here because it shows the distinction between a normal cell and one that has anaplasia. Cancer cells no longer keep the appearance of their parent cell. So that's what's getting concerning. And with it, you'll hear the term malignant and you'll hear the term cancer. Both of these are kind of in reference to the same abnormal growth. Cells become more malignant, they're smaller and rounder. So under the microscope, different types of cancer cells can look alike rather than looking like their parent cell. So what you'll see sometimes is people will kind of reference what the cancer cells look like opposed to the parent cell, because at this point it looks more like the cancer than it does that parent. They also have large nucleic cytoplasmic ratio. So cancer cells have a large nucleus but smaller cell space. With that, this means that the nucleus accompanies most of the space within this cancer cell, especially during mitosis, creating that larger nucleic to cytoplasmic ratio. And if we think about that, that's going to cause issues when it comes to the functionality of the cell. That's mostly the reason why we talk about this, is so that way we kind of understand this cancer cell is not going to be giving the how do I say it, right functions as it would if it was looking exactly like its parent cell. Functionality, cancer cell function is partially or completely lost. Cancer cells serve no useful purpose. So that's why a lot of times we're just going to remove the cancer, or we're going to use medications or chemotherapy agents or radiation in order to get rid of this. Because at this point, this cancer is not really doing anything. All it's really doing is basically stealing nutrients from other areas and not actually helping with any functionality. Your loose adherence and migration. So basically, due to the fact that they can't really adhere to one another, it's typical for them to break off from the main tumor. So this concept here, we'll talk about more when we get into staging, because some of our cancers, depending on if they've migrated or not, we can place it at a different stage of the cancer. And a lot of that comes back to how are we going to talk to this patient therapeutically? Migration occurs because cancer cells do not bind tightly together and have many enzymes on their cell surfaces. So basically the cells slip through the blood vessels in between tissues. Cells spread from main tumor site to other body sites. And these cancer cells invade other tissues, both close by and more remote from the original tumor. Okay. So the next thing they lose is the contact inhibition. So basically what happens is the contact inhibition does not occur. Cells have lost cellular regulation even when all sides of the cells are in continuous contact with surface of other cells. It's hard to manage the disease because of this. So let me show you here. If you look at here, we've got normal contact inhibition versus cancerous cells, which have no contact inhibition. Basically, these cells grow in a culture dish until they cover the surface as a monolayer. Cancerous cells grow in multi-layer clumps and they pile up on one another. So if you look at this, just structurally, what you can think to yourself is this is going to cause issues with things like blood flow. This can cause issues with just kind of being a whole substance that's stuck here. The other thing is our rapid or continuous cell division. Cells do not respond to checkpoint control. Cells re-enter the cell cycle for mitosis almost continuously. Cells do not respond to signals for apoptosis. So basically, we try to fire it off and say, stop growing, but these cells ignore it and they continue to grow and grow and grow. They can also have abnormal chromosomes. Chromosomes that can be lost, gained, or broken, and they can be rearranged with mutated genes. And on here, you can kind of see the different types of chromosome abnormalities. So this chart kind of summarizes everything we just talked about. And it's a very good chart to kind of be able to recognize these things of your characteristics of both your normal and abnormal cells. So for example, you've got things like your malignant cells that has that increased migration and invasive growth, opposed to your normal cells, which aren't going to have that invasive growth. And just kind of, it's basically everything we talked about, just summarized in a very neat chart. So I like this because it kind of puts in perspective of the differences between benign and malignant. Because most people can kind of understand that if it's a normal cell, I'm not as concerned as if it was something like a malignant cell. And like I said, one of the things that we are very concerned about with our malignant cells are the continuous growth as well as that migration. So those are like the ones that when you're looking at it, that's what you want to know about. So the next thing we're going to talk about is just cancer overview. These are things like our risk factors, preventions, manifestations, diagnostics, and nursing considerations. So it's quite a bit all together at once. This is just some helpful terms that are helpful when you're going over this chapter. It's things like our cellular regulation, things like carcinogenesis, malignant transformation, all these kind of terms that you might see. You can kind of come back here and see, okay, what's a quick definition of it? More helpful terms. These are some selected cancers and where they originate. So I felt like this would be kind of a, what's it called? Helpful when you're kind of stuck on an NCLEX question, you're trying to figure out what they're talking about. So carcinomas, they begin in the epithelial tissue. So those are things like your skin, gastrointestinal tract, lung, breast, and uterus. You've got things like your angiocarcinomas, which arise from the glandular organs. So all these kind of originate at different areas. So this is what I was talking about before when we said that cancer cells start getting a similar look to one another. So certain cancer cells that begin in certain tissues might be referred to as your carcinoma, for example. We've got things like our leukemias, our lymphomas, our multiple melanoma, our different types of blood cancers. And this is another chart that just kind of tells you where these different tissues of origin are. It's kind of helpful, especially if you decide that you want to go into surgery, to kind of be looking at, okay, so this carcinoma came from that epithelial gland. So it kind of puts in perspective of where it's coming from. And plus, when you're kind of reading through a chart, you can kind of get a better idea of, okay, so if I've got an for example, osteoma, that means that it is a bone cancer. So I can start thinking about it, start preparing myself of what sort of things do I want to look for. And it just helps in general to kind of know your prefixes, because it just makes it easier when you're going in. So our risk factors. Our risk factors are things like age, race, genetic disposition, exposure to chemicals, viruses, tobacco, alcohol, exposures to certain viruses, bacteria, sun exposures, and diet high in red meat and fat and low in fiber. Older women most commonly develop colorectal, breast, lung, pancreatic, and ovarian cancers, while older men most commonly develop lung, colorectal, prostate, pancreatic, and gastric cancers. And if you think about it, it makes sense for it. With your older males, you have to have a prostate in order to have prostate cancer. So it makes sense why you would see more adult men with a prostate cancer than you would adult women. Same thing with your ovarian cancer. You have to actually have ovaries in order to have ovarian cancer. This here is just selected sites of new cancer cases and deaths for the United States and Canada. And it comes from 2020. So with this, it just kind of shows what was the most prevalent for it. Estimated new cases as well as your estimated deaths. So you can kind of see that there are some cancers that are a little bit, I guess, more likely to cause death than others. So they're a little bit harder to kind of handle. So we've got different types of primary prevention. So with this, we've got avoidance of known or potential carcinogens. So you want to teach adults to use skin protection during sun exposure to avoid skin cancer. So even if the sun is blocked by clouds, you still want to make sure that they're using some sort of skin protectant. Modifying associated factors. So there are some conditions that increase risk. So you want to adjust lifestyles to help decrease risk. So for example, limiting your intake of alcohol to no more than 1 ounce per day, limiting number of sexual partners. So there are some cancers that can be associated with these. So you want to modify it in order to decrease your risk. And it is important. I know sometimes in nursing school, we kind of glance over some of the prevention, but the way our healthcare is working, a lot of our latest evidence is all kind of based on prevention. So you do want to make sure that you know what your preventions are, so you can be a well-rounded nurse. So that way you can let people know, hey, make sure to wear your sunscreen when you go out to the sun. It's much easier to prevent somebody than to kind of treat once they've already gotten sick. Another sort of prevention would be removal of at-risk tissues. So that would be things like removing moles to prevent conversion to skin cancer, or removing breasts to prevent breast cancer. Chemotherapy prevention: use drugs, chemical, natural nutrients, or other substances to distribute one or more steps important to cancer development. So basically use of aspirin to reduce the risk of colon cancer. Vaccinations, doing things like receiving your human papillomavirus vaccination. So making sure that people understand why they should get the vaccination. One of the things that I feel like helps a lot when it comes to patient education in general is explaining the why, not just telling them get your vaccination, but explaining to them, what does it do? How does it benefit them? Because you'll have a lot less grief with it if you actually kind of go through the steps of it. So these are some of your secondary preventions, and these ones are very important to know as well, because it's important to know who should be getting these preventions and who you should be talking to. So your mammogram is annually for females 45 to 54 years. At 55 years, clients can transition to every 2 years. Earlier, if there is a family history. So with it, if your patient has a family history of breast cancer, then you want to make sure you include that in the education piece. So if you're talking to a group of women, or if you're kind of just talking to a female client or a female patient, you just want to make sure that they know that if they have that family history, then you want to go ahead and start screening at an earlier age. This way we can see that they've got it and maybe start some of those preventative things. And a mammogram is just an X-ray imaging to detect for the presence of a tumor or lump in the breast. A clinical breast exam should be every 3 years for clients 20 to 39 years, and annually for clients older than 40 years. And basically what this is used for is to check for breast cancer. Physical examination can be done by a health professional, and the general appearance is checked. A colonoscopy, which is just an imaging test of the colon for any abnormalities using a colonoscope. And this should be at age 50 and then every 10 years. Fecal testing, which usually they'll use a fecal occult blood test, which is basically a lab test used to check stool samples for hidden occult blood. And with it, this test should be annually, or stool DNA test every 3 years. Prostate screening. So what they'll do is a prostate specific antigen testing, which is a blood test used to screen for prostate cancer. And it's basically a test to measure the amount of prostate specific antigen. PSA is a protein produced by both cancerous and non-cancerous tissues in the prostate. And the prostate is that small gland that sits just below the bladder in males. And with this, you want to do it annually for males 70 years and older. And if there is a family history, once again, anytime you've got that family history, you just want to start these preventions earlier. Screening for gene mutations. for clients with a strong family history of for colon or breast cancer. And then a Pap test, clients age 21 to 29 every 3 years, clients age 30 to 65 every 5 years, which HPV DNA test, or every 3 years with a Pap test alone. So once again, those are all of our primary and secondary preventions, and they're just as important to talk about as what to do once we actually have the disease. So the next thing we wanted to talk about are our manifestations suggesting malignant disease. So these are our 7 warning signs that come from the American Cancer Society. So the kind of good thing about this is these warning signs come in the form of caution. So I always like when we have something that we can use to make it easier when we're trying to study. So with it, the American Cancer Society came out with this caution. So C stands for changes in bowel or bladder habits. Now, when we talk about changes in bowel and bladder habits, I'm not talking about somebody ate something they weren't supposed to and now their stomach's upset and suddenly they're either going to the bathroom too much or not enough. What we're talking about in this sense is I didn't change my diet, but suddenly my bowel or my bladder habits are not what they used to be. Maybe I'm not able to pee, maybe I'm peeing too much. A sore that does not heal. Unusual bleeding or discharge, and that can be from pretty much any of the orifices. T, thickening or lumps in the breast or elsewhere. I, indigestion or difficulty swallowing. O, obvious change in a wart or mole. Or N, a nagging cough or hoarseness. So anytime you've got this kind of hoarseness that lasted for more than 2 weeks, you want to make sure that your patient knows to let their provider know that, hey, I've had this hoarseness for longer than 2 weeks. Some of the other manifestations suggesting malignant disease include things like weight loss, fatigue, weakness, pain, nausea, and anorexia. So we've got different types of diagnostic procedures. We've got imaging tests. So that would be things like our just general scans, biopsies, which actually take a portion of the tissue to look at it under a microscope to see, does this look like it? So all that stuff that we talked about before with our normal versus benign versus malignant, it comes back to that biopsy where we take a portion of the tissue, look at it under a microscope and determine, does this look the way it should? Our MRIs, our CT scans, our fluoroscope, our PET scans, and our nuclear imaging. So PET scans, and I do have a video on here for you all. I won't put it on this recording, but it is uploaded to Momentum. So what happens with a PET scan is they've got these radioactive tracers that are attached to glucose. As tumors are metabolically more active than normal tissues, the tracers will brighten that tumor and reveal the blood supply to the tumor. So basically it kind of lights up this tumor so we can see, okay, I see it glowing there. For the test, client or patient should avoid carbohydrates, especially sugar, 24 hours before the test. High protein meals are encouraged, and NPO except for water and meds 6 hours before the test. And here we've got just kind of like a picture of what they're talking about, how that sugar goes in there. But if we think about it, it makes sense why we would avoid carbohydrates, because these tracers are all attached to glucose. So that's why, like, when it comes to our patient education, and I know I keep on like kind of drilling in patient education, but it's very important that they know how to do the proper steps before they take these tests, because you just want them to follow what they're supposed to do. So that way we get the best, most accurate information. Like I said, I won't put this video on, but if you want to watch it, it should be uploaded to helpful, I think it's helpful documents or helpful material or something like that under Momentum. Okay, so the next thing we're going to talk about is grading and staging of our cancer. So grading, and we're going to mostly stay in grading and staging. We're not going to get too much into the tumor chromosomes. So grading classifies cellular aspects of the cancer. Staging classifies clinical aspects of the cancer. So grading, we're talking about cellular. Staging, we're talking about clinical. So what are we doing clinically? So with our grading, some cancer cells are more malignant than others. So this is where we use the terminology well differentiated versus undifferentiated or poorly differentiated. So well differentiated, the cells look like normal cells and they tend to grow slowly. So those are things like our kind of like benign tumors, I guess you could say, but it's basically my cells look the way they should. Undifferentiated means that the cells do not look like normal cells and they tend to grow very quickly and spread. So that's where you'll get like a higher grading for it. And this here is just another kind of table from your book. And what it shows is what's happening with the different grades you have. So grade X means you can't actually determine it, while grade 4 means cells are poorly differentiated. So let's kind of break this down. If it's poorly differentiated, what do we think that means? Yes, it's malignant. That means that we are concerned that this one is a more, I guess, dangerous cancer cell, and they retain no normal cell characteristics. Determination of tissue of origin is difficult and perhaps impossible. So if you're taking care of an oncology patient and you see that they're a G4, that means that we're looking towards more palliative care more than likely, because that means that this is a very poorly differentiated cell and they don't have those normal cellular functions anymore or cellular characteristics. Staging, we tend to use the tumor node metastasis or the TNM system. So T stands for tumor, node stands for nodes like the lymph nodes, and M means metastasize. So this is another example of the TNM classification, where it's kind of telling you where the primary tumor is, in which regional lymph nodes are involved, and distance metastasis. I like this example here because it really kind of breaks down the different stages. So in it, we have stage 1. This all comes back to prostate cancer stages. So stage 1, the cancer is small and only in the prostate. Stage 2, the cancer is larger and may be in both lobes of the prostate and is still confined to the prostate. And then we start getting into stage 3 and 4. Stage 3, the cancer has spread beyond the prostate. In stage 4, the cancer has spread to other organs, such as the bone, and is referred to as metastatic cancer. If prostate cancer spreads or metastasizes to the bone, you have prostate cancer cells in the bone, not bone cancer. And I'll go ahead and repeat that one more time. If the prostate cancer spreads or metastasizes to the bone, you have prostate cancer cells in the bone, not bone cancer. So it's very important for us to make sure that our patients understand what it means about this metastasizing, and that our patients understand what it means when they've got cancer. So if you have prostate cancer, you don't suddenly develop bone cancer. What it is your prostate cancer is now located in the bone. And if you think about it, why is it so important for us to know where the cancer comes from? I'll give you a few seconds to kind of think about that. Because you want to know where the origin is, because if we know where the origin is, then we can kind of figure out and kind of play backup to see what's going on with it. So that's why I like when you're talking to a patient, just let them know that even if it metastasizes, even if your prostate cancer goes all the way up to your brain, it's still prostate cancer. It's just a metastasized prostate cancer, because it would be inappropriate for them to say that they suddenly have brain cancer, because brain cancer is different, like it's that different origin than it would be with prostate cancer. Right. So the next thing we're going to talk about is the consequences of cancer. So these are some of the complications that can arise if we just have cancer growing without kind of dealing with it. So with it, we've got decreased immunity and blood producing function, altered GI structure and function, motor and sensory deficits, and decreased respiratory function. So your decreased immunity and blood producing function, This occurs most often with your leukemia, your lymphoma, or any of your cancers that invades the bone marrow and reduces the production of white blood cells, red blood cells, platelets, causing that thrombocytopenia. So with it, whenever I think of your blood, you want to think about all the different functions that your blood does. So your white blood cells, what do? They fight infection. So if I've got a decrease of my white blood cells, what is my patient suddenly at risk for? Infection. Same thing with if I've got a decrease in my red blood cells, what am I at risk for? Anemia. Red blood cells transport my oxygen, so I'm concerned about me not having enough oxygen. Then you've got things like our platelets. If I don't have enough platelets, what's going to happen to my patient? They're going to bleed. Now with this, it can be caused by either the cancer or the chemo agent if they're having that. So they're going to experience things like weakness, fatigue, and bleeding. Your altered GI structure and function, impaired absorption and elimination related to tumor obstruction or compression. So your tumors can increase the metabolic rate, which increases the need for proteins, fats, and carbohydrates. Because if you remember, it's that big cluster of cells. So what's happening is all your nutrients are kind of going into that cluster. The problem is it's not giving it to the rest of the tissues. It's just going to this big, huge cluster, which means that you're not getting the proteins, fats, or carbohydrates that you need. So that's why it's causing that increased need for it, because your body senses that it needs more, but instead of sending it to where it needs to go, it's just going into that cancer. Liver tumors can reduce function and lead to that malnutrition as well. So your motor and sensory deficits, these occur when cancers invade the bone or the brain or compress nerves. So anytime you've got a cancer that's just basically kind of blocking that area or causing like a disruption of the bone, then you can have that motor and sensory problems. Bone metastasis cause pain, fractures, spinal cord obstruction, and hypercalcemia, so decreased mobility. Sensory changes occur if the spinal cord is damaged by the tumor pressure or compression. Sensory, motor, and cognitive functions are impaired when the cancer is in the brain, and pain is often significant, especially in terminal stages of the disease. Finally, we've got a decreased respiratory function. It disrupts respiratory function and gas exchange. So basically, if you have a tumor in the airway, it can cause obstruction. Lung capacity is decreased and gas exchange is impaired. Tumors can compress blood and lymph vessels in the chest, blocking blood flow through the chest and lungs, causing pulmonary edema and dyspnea. So these are some of our just kind of general nursing considerations. You want to be aware of where the tumor is pushing against. So things like our spinal cord compression. So I've got that kind of picture here with the spinal cord compression. It can be that spinal cord compression can be that complication of cancer. Tumor basically presses against the spinal cord. And depending on where the tumor is pressing, the patient may have various manifestations related to the location. You've got three main segments of the spine: the cervical spine, the thoracic spine, and the lumbar spine. So if you think about it, the cervical spine is the top portion of the spine. So that's like C1 through C7. So damage to this area could potentially occlude arterial blood flow, affect motor control throughout the entire body, and it can manifest itself as things like pain in the head, jaw, arms, numbness in these areas. And you can have difficulty breathing or even loss of bowel and bladder control. So you just kind of want to think about, where is this going? Superior vena cava syndrome is caused by the obstruction of the superior vena cava, and we will discuss this more in our oncological emergencies. You also want to be aware that tumors are highly vascular and can hemorrhage. So you just want to be aware that since they're so vascular, if they do end up popping or anything of that nature, then it can be an internal bleeding problem. Tumors can also release more calcium than the body can handle, causing hypercalcemia. So with hypercalcemia, you can get things like dysrhythmias or acute kidney injury. And always be aware of the implications of your CBC. leukopenia and sepsis. So if I don't have enough white blood cells, I can develop sepsis. Thrombocytopenia, so decreased platelets, hemorrhage, and anemia. So one thing I will say is as you continue on, especially because you're preparing for NCLEX, make sure you've got a good understanding of what your lab values mean. Like one of our best things we use as a nurse is definitely our lab values. Because for example, if we've got a patient who has thrombocytopenia, we want to watch out for things like epistaxis, so like things like a nosebleed. We just want to watch out for this so that way they don't just keep on bleeding. And on here you can see where we've got the normal spine and then the tumor that's kind of pressing against it. Okay, so now we've got our cancer management. So these are our pharmaceutical and non-pharmaceutical treatments. Once again, these are just general terminology for our management of cancer. We've got things like alopecia, loss of hair, nadir, which is the period in which the bone marrow suppresses. The suppression is the greatest and the patient is at the highest risk for complications. So we've got all kinds of different terms that might help you as we continue. Okay, so general overview of treatment options. You focus on the removal or destruction of cancer cells. Treatment can be curative, so we can actually cure the cancer, or it can be palliative. And collaboration between various healthcare professionals is very key to the management of the patient. Because when you think about this, there's a lot of different things going on with your patient who's the oncology patient. We've got things like, depending on what kind of cancer they have, they may develop issues with walking, or they may develop where they need occupational help. So just making sure that you're communicating with the other healthcare professionals. So we've got all kinds of treatment options, and we went ahead and we kind of bolded the top 3 because these are typically the treatments of choice. So you've got surgery, radiation, chemotherapy, hormone therapy, immunotherapy, targeted therapy, photodynamic therapy, and supportive treatment. So the first one we are going to talk about is surgery. So surgery is where we're just going to actually just remove the cancer a lot of times. And we've got different types of surgeries. So we've got prophylactic surgery. So prophylactic surgery removes potentially cancerous tissues as a means of preventing cancer development. So prophylactic is, for example, removing the opposite breast in a patient who has a genetic mutation to prevent cancer in the unaffected breast. Diagnostic surgery, excision biopsy, is the removal of all or part of a suspected lesion for examination and testing to confirm or rule out a cancer diagnosis. So with this one, it's basically, I'm going to see, it's kind of like our biopsies. Well, there's excisional biopsy right there. Curative surgery removes all cancer tissue. So surgery alone can result in a cure when all visible and microscopic tumor is removed. It is most effective for small localized tumors or non-invasive skin cancers, such as your basal lesions, basal cell lesions. So that's like kind of our different types of surgeries for this first part. You also have debulking surgery, which removes part of the tumor if removal of the entire mass is not possible. So if you've got this cancer that is so large, but we kind of just want to remove part of it, this may alleviate some of the symptoms and enhance the success of other cancer treatments and increase survivability by just kind of removing part of it. Palliative surgery focuses on providing symptom relief and improving quality of life, but is not curative. So palliative is not going to cure their cancer. It's just basically allowing them to be more comfortable. So for example, removal of a tumor tissue that is causing pain, obstruction, or difficulty swallowing to help improve that quality of life. Reconstructive surgery increases function and enhances appearance. So this can be things like breast reconstruction after a mastectomy, bowel reconstruction, revisions of scars, and cosmetic reconstruction in the head and neck. So it's kind of just giving them that better quality of life. So as the nurse, you want to provide preoperative care, prevent postoperative complications, fluid and electrolyte imbalances, hemorrhage, shock, etc. Educate patients on drains, wounds, and implanted devices specific to their surgery. So when it comes to this kind of drains, wounds, and implanted devices, my suggestion would be if you kind of struggled with some of the earlier concepts, like, you know how I showed you that list of different chapters, it might be worth going back to that chapter and seeing, okay, if they remove this cancer, what are my nursing actions? And in nursing school, we tend to talk about perioperative and postoperative, but not really in the operating room itself. The operating room itself as a nurse is like a whole different kind of ball game. So there's a lot that goes into it. But for the most part, when we talk about it in NCLEX world, we're mostly talking about that perioperative or postoperative. So with it, you want to provide psychological support for patients coping with body image changes and diagnosis. So you want to make sure that you're being empathetic with your patient and kind of helping teach them about some of those strategies. You want to assist in the development of strategies for patients dealing with loss of function, organs, tissues, or limbs. So this right here is kind of a great way to kind of connect with things like occupational therapy, physical therapy, because a lot of times your physical therapist will be way better at kind of explaining how to do the physical attributes than maybe we can. So that's why I always say try to be nice to everybody in the hospital, because it kind of allows you to get a better understanding of it. Provide interprofessional collaboration between physical, speech, respiratory, and occupational therapy as needed. And like I was saying before, I cannot stress this enough. Make sure that you're being nice to all these different disciplines, because honestly, we all work together to help the patient. Okay, so the next thing we're going to talk about is radiation. Right, so radiation therapy destroys cancer cells with minimal exposure to normal cells. Cells damaged by radiation either die or become unable to divide. Gamma rays are used most because of their ability to penetrate tissues and damage cells. Okay, so we've got two different types of this radiation, and I kind of split the slides to talk about basically our internal radiation versus external. So our bronchotherapy is short for close therapy. Radiation comes into direct, continuous contrast with the tumor tissues, provides high dose of radiation with limited amount to surrounding tissues. Radiation is within the client. Client emits radiation, and it's hazard to those around them. Then you've got external beam radiation. It's distant treatment. Radiation source is external to the client or to the patient. So you got photons, protons, and electrons. And photons are just the same beams used in X-rays, but X-rays have a much lower dose. Protons are particles with positive charge. Electrons are particles with negative charge. Now, what I will say about this radiation is definitely try to pay attention to what you need to do as the nurse with these different situations, because especially if you decide that you want to go into oncology, and just for NCLEX purposes in general, it's important to know what your standards of care are, as well as what you're going to tell other people. So we're going to start out with our brachytherapy, which is our brachytherapy, which is our internal radiation. So radiation that is placed close to the target tissue. So it can be something like placement in a body orifice or body cavity. It can be IV. So basically like with our iodine, so absorbed by the thyroid, provides radiation to the tumor in limited amounts to the surrounding normal tissues. Most patients remain in a medical facility until the brachytherapy is complete. Patients who receive seed implants may get to go home. So with this, you just want to make sure that visitors are limited, particularly your pregnant women and children. So With it, you can have your client excretions. So talking about excretions, this is something that's kind of important to kind of grasp with it, is ingestion isotopes enter body fluids, eventually eliminated in waste products. Waste are radioactive, must ensure that they are not directly touched by anyone, handle waste according to the guidelines set by the institution. So client excretions, radioactive until the isotope has been completely eliminated from the body. While isotope is in the patient, ensure no one touches client's excretions. So it's important to make sure that the patient understands that their excretions are only radioactive while the isotope is in the body and while they're still excreting the radioactive material. Once the isotope has been excreted, they are no longer radioactive. This means that during therapy, the patient can go home and not worry about radiation in their excretions, but when they come in and have the seed, ribbon, or capsule placed, they are worried about their excretions. Therefore, not all bodily fluids are treated as radioactive, only bodily fluids with active isotope in the system. So it's a lot of words to basically just explain that when we worry about excretion, it's when the isotope is still being digested by the patient or when they're still excreting things that can have that radioactive material. Now, these ones, I cannot stress this enough, but make sure that you know all of these care of patient with sealed implants of radioactive sources, because these are like very easy kind of like NCLEX-y, I guess, questions, and they're very much like cut and dry. You want to assign the patient a private room with a private bath. Once again, if you think about it, it makes sense because if they've got some sort of implant with an isotope, we don't want them to spread that radiation to someone else. You want to place a caution radioactive material sign on the door of the patient's room. If portable lead shields are used, place them between the patient and the door. Keep the door to the patient's room closed as much as possible. Wear a dosimeter film badge at all times while caring for patients with radioactive implants. The badge offers no protection, but measures a person's exposure to radiation. Each person caring for the patient should have a separate dosimeter to calculate his or her specific radiation exposure. Now, this one here, definitely for yourself and for your own protection, make sure that you are wearing that badge so you know how much radiation you have received. Wear a lead apron while providing care. Always keep the front of the apron facing the source of radiation. Do not turn your back toward the patient. If you are attempting to conceive, do not perform direct patient care, regardless of whether you are male or female. Nurses who are pregnant should not care for the patients. Do not allow women who are pregnant or children under the age of 16 to visit. Limit each visitor to 1/2 hour per day. Be sure visitors stay at least 6 feet from the source. Never touch the radioactive source with bare hands. In the rare instance that is dislodged, use long-handled forceps to retrieve it. Deposit the radioactive source in the lead container kept in the patient's room. After the source is removed, dispose of dressing and linens in the usual manner. Other equipment can be removed from the room at any time without special precautions, and do not pose a hazard to other people. So with it, if you're thinking about this and you're trying to be like a proactive nurse, what's something that you would want to make sure that you have at bedside with you? Long-handled forceps, honestly. That way, if the isotope comes out or it gets dislodged, you can pick it up. Never ever pick up the isotope with your bare hands. There's a reason why they say they want those long-handled forceps. The next one we're going to be talking about is external beam radiation therapy. So this one's also referred to as teletherapy. External beam radiation therapy comes from a machine that aims radiation at the cancer. So it's a local treatment. So an example would be lung cancer will only hit patient's chest, not the whole body. It's delivered in relatively small doses over the course of several weeks, and it's unique to the patient. So that's kind of one interesting thing is that they do it based off the patient themselves. Patient is not radioactive and is not hazardous to others. So that's kind of the difference between this external radiation opposed to the internal radiation. Because internal radiation, I'm taking the isotope into myself, so my excretions are radioactive. While this external radiation, I basically just have the beam coming at me. Different beams are used as well as different types of therapy. So you've got different types of beams, which are those photons, protons, and electrons that we talked about. Your photons, like I said before, they're the same beams used in X-rays, but X-rays have a much lower dose, and they can reach tumors deep within the body. They do not stop even when they reach the tumor, so they will go into the normal tissue. Your protons are particles with positive charge. They can reach deep tumors. However, they do not scatter radiation. Electrons are your particles with the negative charge. They cannot travel very far through body tissues, and use is limited to tumors on the skin or near the surface of the body. So on here, this is a picture of a man receiving external radiation. He's got his radiation mask, proton beam therapy for ocular melanoma using a novel 3D treatment planning. So like I said before, that's with the positive charge. So they can reach those deep tumors within the body, but they're not scattering the radiation on their path. And here's another long list of things that you need to know. So your skin protection, because with your external radiation, what we're more concerned about is our skin protection. So you want to wash the irritated area gently each day with either water or mild soap, and water is prescribed by a radiation therapy team. Rinse soap thoroughly from your skin. Avoid friction to the area being treated. Use your hand rather than a washcloth. If ink or dye markings are present to identify exactly where the beam of radiation is to be focused, take care not to remove them. Dry the treatment area with patting rather than rubbing motions. Use a clean, soft towel or cloth. Use only powders, ointments, lotions, or creams that are prescribed by the radiation oncology department on your skin at the radiation site. So once again, only use powders, ointments, lotions, or creams that are prescribed. So you don't want to be using anything unless the provider has told them it's okay to use. Wear soft clothing over the skin at the radiation site. Avoid wearing belts, buckles, straps, or any type of clothing that binds or rubs the skin at the radiation site. Avoid exposure of avoid exposing that area to the sun. Protect this area by wearing clothing over it. Try to go outdoors in the early morning or evening to avoid the more intense sun rays. When outdoors, stay under umbrellas or other forms of shades during the times when the sun's rays are more intense, so 10 a.m. to 4 p.m., and avoid heat exposure. So these are some of our side effects with it. So location of radiation results in different side effects. And you can see that on page 381. Multiple factors can cause a variation to the side effect. So total radiation dose, duration of radiation, concurrent chemotherapy treatment. So for example, with an oropharyngeal cancer, you might develop mucosal edema, which is life-threatening. Because if you think about it, that's where the radiation is going, and they might end up developing edema in that location. For the brain, where if you have brain cancer and they are doing radiation there, they may develop alopecia and dermatitis of the scalp. It's non-life-threatening, but they can also develop things like cerebral edema or intracranial pressure. You do have some systematic side effects that are just kind of general for everyone. It doesn't matter what kind of cancer it is. And that's things like your altered taste and fatigue related to increased energy demands needed to repair damaged cells and can last for months. So with it, if you know your patient is getting external radiation therapy, you're going to expect them to feel very tired. And then finally, another side effect is bone marrow suppression. Anytime you see bone marrow suppression, what you're really thinking about are things like the decrease in your white blood cells, red blood cells, and your platelets. So you're watching for those kind of manifestations. So here, like I said, are just some of the acute effects. For example, we've got things like our oropharyngeal cancer, where they can develop things like your mucosa edema. So looking at the different locations, what you might see as the effects. So for your head and neck, like I said, you can have those taste changes, dental issues, anything of that nature. What I would do is when you're looking at these, look at the ones that are going to cause the most problem to your patient. For example, if I have brain cancer and we give them radiation, I'm going to be concerned about that cerebral edema and increased intracranial pressure. And the reason I'm so concerned about those ones is because that can cause neurological issues for my patient. So just kind of looking at these and seeing which ones are like that, it'd be kind of helpful to kind of put it together. And then these are some of the late effects. So those ones were early. These are some of the later ones of kind of continued radiation. So the next thing we're going to talk about is our chemotherapy. So I've got this video here, and like I said, you can see it on Momentum as well if you want to watch it on there. So chemotherapy can be systematic or local medications. They can be used to cure and or increase survival rate by damaging cell DNA and interfering with cell mitosis. So rapid growth tumors are more sensitive to chemotherapy. And these are our different classifications. We've got things like our alkylating agents, our anti-metalobite, our antibiotics, so on and so forth. Now with it, all of these can cause bone marrow depression. So you do want to keep watching your patient for any of those bone marrow suppression signs and symptoms. So administration key points for giving IV medications. Giving IV chemotherapy requires special education and handling. So you do have to be chemo certified in order to give it. So it can only be given by those certified chemotherapy registered nurses. Special PPE needs to be worn during the preparing, giving, or disposing of chemotherapy agents. Chemo agents are vasicants. So when it means a vasicant, that means that it's a chemical that can damage tissue on direct contact. So this is why they make sure that they're chemo certified, because it can cause a huge problem. So with it, you want to watch for extravasation. And this right here, you can see where it's completely destroyed the tissue. Now with it, the reason why it's kind of important for you guys to know, even if you're not planning on becoming a certified chemotherapy registered nurse, is because you can still have a patient who is receiving that while you're working alongside them. So you just kind of want to make sure to know what you're looking for. Oral medications. So oral anti-cancer drugs are just as toxic to the patient taking the drug and to the person handling the drug as are IV chemotherapy agents. Oral agents can be absorbed through the skin and mucous membranes. So the person who handles and administers these medications need to be using that PPE, same as they would with IV administration. Oral agents must not be crushed, split, broken, or chewed. And these are just some of your general common side effects. So things like bone marrow suppression. Now with it, you want to know what your precautions are for each of these different things. So neutropenia, leukopenia. So if I have a patient who has leukopenia, what do I want to let them avoid? Obviously, anything that's going to make them sick. So things like crowds, things like areas with large populations, things like people with infections. You want to kind of make sure that you're watching them for that. And you just always kind of want to watch for your patients who have metastatic carcinoma, that you're looking for things like leukopenia. And remembering that bone marrow suppression for your patients is going to have a decrease in all cells. This means that they're most likely to develop that neutropenia, leukopenia, and thrombocytopenia. So for your neutropenia, like I said, you just want to make sure you are enhancing the immune system, monitoring their temperature. Consider any temperature elevation in a client with neutropenia as a possible sign of infection and reporting that to the provider. Anemia, administering oxygen therapy as needed. Thrombocytopenia, administering prescribed platelet transfusions if you need. and then implementing bleeding precautions. So things like avoiding IM injections, avoiding aspirins. The other thing that they can develop is alopecia. So that's hair loss 2 weeks after start of treatment, hair growth 1 month after last chemotherapy treatment. So with it, you can do things like apply ice to the patient's scalp during chemotherapy to slow hair loss. You want to use gentle shampoos, hats, scarves, and sunscreens. And you can always refer them back to the American Cancer Society. And then you've got anorexia, nausea, vomiting, and GI issues. So make sure that before your patient has any of this chemotherapy, that you give them something like ondansetron to keep them from vomiting. Managing their diarrhea, providing soft, bland, high protein foods, and rinsing the mouth kind of with a topical anesthetic to keep them from like having any pain with their sores. For things like elevated uric acid, crystal, and uric stone formation, make sure not to forget your pharmacological agents. So you can do things like ask for an order for allopurinol, or just basically like make sure that you're giving that medication. So with the elevated uric acid, aside from just administering allopurinol, you can also increase the fluid intake. Some of the other common side effects are things like mucoitis, which we'll talk about in the next slide, and then some cognitive functions. So sometimes they'll have reduced ability to concentrate, recall information, and learn new information during the treatment and for months to almost about 3 years following the treatment. A lot of times this is referred to as chemo brain, especially they've kind of termed that phrase for women who are treated for breast cancer. So mucoitis. Mucoitis is just that inflammation of the mucosa. Stomatitis is location in the mouth. So with it, it's a common problem for anyone who has received radiation to the head and neck, as well as chemotherapy. So with it, you want to provide frequent mouth assessment and oral hygiene. So this includes teeth and mouth cleaning. So you just want to make sure that you're using mouthwashes. And with it, you don't want to use alcohol-based mouthwashes. It's better if you use plain water or saline for those oral rinses. You want to use soft, bristled toothbrushes and avoiding overly spicy or sour foods. And like I said, stomatitis is the one that's located in the mouth. This is another video here, and like similar to our other ones, this one is going to be located in momentum. So this is a neutropenic precaution refresher, because like we've been talking about, you can have bone marrow suppression. So you just kind of want to make sure that you're adhering to these precautions. So you want to assign the patient to a private room, have the patient remain in the room unless they need to leave for a diagnostic procedure or therapy. In this case, you want to place a mask on the patient during transport, protect the patient from possible sources of infection, such as live plants, stagnant water, contaminated equipment, have the patient, staff, and visitors perform frequent hygiene, restrict visitors who are ill, avoid invasive procedures that could cause a break in tissue, such as rectal temperatures or thermometers, injections, indwelling urinary catheters unless necessary. Keep dedicated equipment, so things like blood pressure machine, stethoscope in the patient's room. Follow policy regarding fresh water or fresh flowers and plants in the room. So not putting any of those in the room. And just kind of remembering that neutropenic precautions are designed to keep the patient from these outside sources of infection. Bleeding precautions. So one of the things that your bone marrow suppression or bone marrow depression can cause is thrombocytopenia. So you need to kind of know what your bleeding precautions are. With that, it's things like using electric shaver, use a soft bristled toothbrush, do not have dental work performed without consulting your cancer healthcare provider, do not take aspirin or any aspirin containing products unless prescribed, Read the label to be sure that the product does not contain aspirin. Do not participate in contact sports or any activity likely to result in you being bumped, scratched, or scraped. Avoid hard foods that could scrape the inside of your mouth. Eat only warm, cool, or cold foods to avoid burning your mouth. Check your skin and mouth daily for bruises, swelling, or areas with small reddish purple marks. Notify your healthcare provider if you are injured, have menstrual bleeding that is excessive for you, see blood in your vomit, urine, or bowel movement. Avoid trauma with intercourse. Avoid anal intercourse. Take a stool softener to prevent straining during a bowel movement. Do not use enemas or rectal suppositories. Do not wear clothing or shoes that are tight or that rub. Avoid blowing your nose or placing objects in your nose. Avoid activities that increase the pressure in your brain. So these are all of our different thrombocytopenia precautions. And like I said, a lot of times oncology goes hand in hand with your hematology. So just kind of making sure that you remember these different precautions. These are some of our alternative therapy, such as hormone, immunotherapy, targeted therapy, photodynamic therapy, and supportive therapy. So with this, we've got kind of like a general overview. So our hormonal therapy is effective against tumors that are supported or suppressed by hormones, so prostate or breast cancer. So by giving a similar hormone, uptake of the support hormone is blocked or production is reduced. So we usually use hormonal therapy with that prostate or breast cancer. Immunotherapy alters a patient's biological response to cancerous tumor cells, so things like antibodies, cytokines, and other immune substances are administered to increase the body's defense system. So doing things to kind of uplift our body's defense. Targeted therapy acts on the components produced by cancer cells. Photodynamic therapy involves injection of photosynthesizing agents that is absorbed by all cells in the body. So supportive therapy is assistance for altered body function or to meet emotional support. So this is things like not only therapeutic communication, but also making sure that we're doing everything we can for our patient. So with it, one of the things that I think about a lot is making sure that we are controlling our cancer patients' pain. Now with it, when the cancer starts getting pretty bad and when they start going into things like hospice, and we'll talk about this more when we get into our hospice unit, we are more concerned about making them comfortable than anything else. So with it, if it's something along the lines of they can no longer swallow or anything like that, we really do need to start contacting our healthcare providers and discussing alternative methods. Maybe something like transdermal, maybe something like IV. The main goal is to make sure that we're having alternative pain regimen for them, because you don't want them to be in pain. You also want to make sure that we have alternative means of communication. So for our patients who have cancers in the mouth, larynx, or throat, making sure that we do things like have them write things down, communicate in some other way. And monitoring your patient's nutritional intake and weight, and then making sure that they're aware of your safety issues, and making sure that you're like still giving them that autonomy and letting them have their preferred strategies into the plan of care. So the next thing we're going to be talking about is our oncological emergencies. So our oncological emergencies include our syndrome of inappropriate antidiuretic hormone, our hypercalcemia, our superior vena cava syndrome, our hematological disorders, sepsis, spinal cord compression, and tumor lysis syndrome. So the first one I'm going to be talking about is our superior vena cava syndrome. So this is the compression or obstruction by tumor growth or by clots in this vessel leads to congestion of blood returning to the body. So this can occur quickly or develop gradually over time. And it usually occurs in patients with mediastinal tumors or tumors near the chest wall, or if we have an indwelling catheter. So indwelling catheters can also cause this, because what happens is with that indwelling vascular devices, they can cause superior vena cava syndrome as a result of a blood clot. This type of obstruction can be treated successfully if we give anticoagulations as well as removing the catheter. But for our cancers, what will happen is they've got a tumor and it's basically pressing up against here. And now we've got this engorgement through here. And you can kind of see on this picture as well, how it's completely engorged where we're pushing and we've got all this blood flow here. So this can be painful as well as life-threatening. And it's very important because anytime there's an emergency, since we are now moving forward to being in our, what's it called, more critical care-esque classes, it's important for you to be able to distinguish between early signs and symptoms as well as worsening and alarming and late symptoms. Because when you go out there in the real world of nursing, you're going to want to know, okay, what do I need to look for? So with this, your symptoms result from blockade of venous return from the head, neck, and upper trunk. So some of your early signs and symptoms. So whether it's because your patient has a tumor or whether it's because your patient has a catheter in their neck, these are some of the early signs and symptoms you want to see before things get worse. So one of the early signs are edema of the face. So it's especially around the eyes. So when you have edema around the eyes, it's called periorbital edema. So anytime you see periorbital edema, what we're talking about is that edema around the eyes. And you'll especially see that in the morning, as well as reports of head fullness. So those are kind of subtle signs that you want to look for, because if you see that, then you're going to want to kind of be alert that this could be a potential oncological emergency. As it gets worse, you're going to see patient develops engorged blood vessels and erythema of the upper body. Because remember, looking back at this picture, we've got all this blood flow that's basically being compressed. So then you're going to see edema in the arms and hands, as well as dyspnea. Your alarming symptoms are development of stridor. So whenever you see stridor, that is just basically telling you, uh-oh, things are not going well for my patient. So that's that high-pitched crowning sound, and it's an alarming sign of rapid progression. So stridor is one of those ones that it's kind of NCLEX's way of alerting you that things are not going well for my patient. Your late signs include things like hemorrhage, cyanosis, mental status changes, decreased cardiac output, and hypotension. And if we do not correct this, death can result. And here you can see the appearance of the face, neck, upper arms, and chest in the patient with superior vena cava syndrome. So she's got all that edema kind of pressing through here. So as a nurse, you want to position the patient in that high Fowler's position initially to facilitate lung expansion and use high dose radiation therapy for emergency temporary relief. So I wanted to kind of come back here and talk about a few of these other ones, such as your syndrome of inappropriate antidiuretic hormone. Sorry about that. Okay, so your syndrome of inappropriate antidiuretic hormone. So this occurs with both lung and brain cancers, and it basically happens when excessive levels of antidiuretic hormone are produced. So body retains water, dilation of electrolytes such as sodium in the body. And your key findings are things like nausea and vomiting, which are early, lethargicness, hostility, seizures, and coma. So with it, your nursing interventions would be things like monitoring for hyponatremia and low blood osmolality. You can administer furosemide, which is our Lasix, to kind of pull off some of that fluid, 0.9% sodium chloride, in a hypertonic solution as prescribed for severe hyponatremia. And you want to make sure you're monitoring your vital signs and sodium levels. And this here is just kind of like a picture showing what it looks like. Hypercalcemia is a common complication of breast, lung, head, and neck cancers, as well as leukemia and lymphomas, multiple melanomas, and bony metastasis of any cancer. Some of your manifestations can include things like anorexia, nausea, vomiting, shortened QT intervals, kidney stones, bone pain, and changes in your mental status. For their interventions, you want to make sure you're administering that 0.9% furosemide, panadordite, and phosphate. We talked about that one. Okay. So our hematological disorders can be caused by the cancer itself or the chemotherapy. You can have things like anemia, which is cancer invades the bone marrow. It decreases the number of red blood cells, platelets, and white blood cells. You can also have disseminated intravascular coagulation, which is usually secondary to leukemia or angiocarcinomas. So with your DIC, you want to, what's interesting about it is they basically have where they are bleeding and clotting at the same time. So dealing with that is kind of interesting because you'll have where they'll give like heparin as well as clotting factors. So it's kind of making sure to watch for that. So your nursing interventions are observing for bleeding, applying pressure as needed, being prepared to administer blood clotting factors that have been lost through bleeding. Heparin can also be used to slow the cascade of events that makes the body overuse its blood clotting factors. Sepsis. So yes, your nursing interventions are to observe for bleeding and apply pressure as needed. And then for DIC, being prepared to give both blood clotting factors that have been lost through bleeding, as well as possibly giving heparin. You can kind of see the little picture here. Okay, so sepsis. Pathogens in the body can lead to septicemia and septic shock, which is life-threatening. Patients who are neutropenic are at an increased risk. So you want to make sure that you are obtaining blood cultures, measuring blood levels, and administering antibiotics as needed. You can give vasopressors if the fluid administration is insufficient. Spinal cord compression, we talked about a little bit before, but this occurs when the vertebrae degrade secondary to cancer or tumors invading the spinal column. Without immediate intervention, permanent neurological damage can occur. So your manifestations can be things like changes in sensation, muscle strength, reduced deep tendon reflexes, worsening back pain, and bowel or bladder retention. So your interventions for them would be to plan to administer high-dose IV corticosteroids to reduce inflammation and prepare the patient for possible radiation therapy to relieve that cord compression. There you can see it there. Your tumor lysis syndrome occurs when the tumors are rapidly destroyed, releasing intracellular content into the bloodstream faster than the body can process them. Because if you remember what I said, we basically got this huge kind of cancer that's just taking all these nutrients. So when it pops, you're going to have that rapid release of hyperkalemia, hyperphosphatemia, hyperuricemia. Without correction, this can lead into kidney injury, changes in cardiac function, and death. Older ages increase the risk as well as certain chemo agents, and your manifestations are things like gastrointestinal distress, blank pain, muscle cramps, weaknesses, seizures, and mental status changes. So your interventions, primary concerns are hyperkalemia resulting in lethal dysrhythmias, hyperuricemia, hyperphosphatemia, hypocalcemia. So for your hyperkalemia, you can use things like loop diuretics in order to kind of get rid of some of that potassium. Hyperuricemia, you can use things like alpunerol. For your hyperphosphatemia, you can use things like your phosphate binders. Hypocalcemia, you can give them calcium. And remember, fluids, fluids, fluids. Hydration prevents and manages tumor lysis syndrome by dilation, lowering potassium and uric acid, increasing potassium excretion, and preventing kidney stones. So fluids are kind of a very important thing to think about. And you can see this picture here of our tumor lysis syndrome. These are just some general nursing considerations. It's kind of a repeat of the slide we did before. Being aware of the tumors pushing against, being aware that tumors are highly vascular, and always being aware of the implications of your CBC. So, breaking the news. When presenting a patient with a diagnosis of cancer, the priority of the time is usually psychosocial needs. So you want to use therapeutic communication, and you do not want to preach or offer false assurances. So there's a difference between sympathy and empathy. And I've got this little video here that you can watch that kind of demonstrates the difference between the two. And it's very important that we make sure that we're listening to their needs and not just trying to make ourselves feel better. So these are kind of some optional activities that you can do at home that kind of might help you when you're doing these critical thinking. So the first one is to kind of develop a therapeutic teaching conversation with a patient who is just diagnosed with cancer. So this one is kind of learning how to talk to patients and what you need to do about it. The second one is developing an education plan for someone receiving chemotherapy along with the side effects. And then the third one is developing a precaution plan for someone receiving radiation and remembering both your patient and staff points. And then the fourth one is teaching that care plan for a patient who is neutropenic. Some of your common oncology drugs. So with this, it's kind of looking at different drugs that we use for oncology. And these ones are very common. Tomofexin is usually used for breast cancer. So it's kind of helpful to create drug cards about these just so you're keeping yourself aware of different drugs. All right, as always, thank you, and let me know if you have any questions.